Alright, let's talk about high yield drug digoxin. Well, digoxin, its mechanism is that it directly inhibits sodium potassium ADPase channel, which leads to indirectly inhibition of sodium calcium exchanger, and that causes increase in calcium intracellularly. And when you increase the calcium intracellularly, it's going to cause positive inotrophy. What is positive inotrophy means? Positive inotrophy basically means that you have increased in force of contraction. Inotropy, force of contraction, is increased. And when you increase the force of contraction, guess what? You're going to increase cardiac output, right? Increase in cardiac output. It also stimulates vagus nerve, which decreases the heart rate. So imagine this drug, which is decreasing the heart rate but increasing cardiac output. How beneficial a drug would be, right? Such a great drug. Okay, now let's take a look at this image on the right side. What do we have? So we're here. If you look, you have a calcium. Normally we have a sodium calcium exchanger, meaning calcium is going out in the exchange of sodium coming in, and that sodium would go out in the exchange of potassium coming in. That is all normal. But now it's with digoxin, let's change color. With digoxin in place, you're inhibiting this channel. So when you inhibit this sodium potassium ADPase channel, no sodium will go out and no potassium is going to come in, right? And when no sodium goes out, there is low concentration of sodium outside. So no sodium will be able to come back in, right? Because there is no sodium over there. A lot of sodium is just inside. Let me erase this all again. So when you inhibit this, sodium remains inside. There is low sodium outside, which is going to run this channel, right? If sodium was outside, this would run here. But since we don't have it, now what's going to happen is this channel will not work. When this channel won't work, the calcium also remains inside. So when the calcium remains inside, now let's talk about that. Calcium leads to stimulation of sarcoplasmic reticulum, and that calcium, if you recall, calcium-induced calcium release from SR is going to cause lots and lots of calcium to release. And when lots of calcium release, it causes increase in the tropomyosin binding, troponin, colmodulin binding with the calcium, that causes increase in cardiac contractility, right? So now this is also important. What it is important here is it's going to be calcium bind. So let's just write this. Calcium binds troponin. That when it binds troponin, it leads to sliding of actin and myosin filaments. So you have an actin myosin. So there's a sliding of actin and myosin, which is contraction. So where does the calcium bind? Binds to troponin C, right here. Troponin C. Okay, and that is high yield point. And that causes contraction. And that contraction, we call that what terminology? Inotrophy. Inotropy. Okay, now let's look at some other clinical uses. The clinical uses for digoxin is heart failure, because it is increasing contractility without utilizing oxygen. It is used in AFib because it decreases the conduction in AV node and depression of the SA node. But the thing is, we haven't talked about this thing, right? If you look here, we said it stimulates vagus nerve. It stimulates the vagus nerve. And that vagus nerve is going to decrease the heart rate. Okay, so when you decrease the heart rate, it's called chronotropic effect, decrease in chronotropy. Okay. Now, what they have mentioned here is simple. So this digoxin, it not only inhibits, let me erase this, not only it inhibits the sodium potassium ATPase at the level of cardiomyocytes, but also it inhibits the same channel in the neuronal pathway. And that causes same sodium potassium channel inhibition in the neuronal pathways that will lead to decrease in sympathetic nervous system stimulation, which is decrease in SA node and decrease in AV nodal conduction. Okay, and also in turn, as you know, we have a system, it's called predominance. When you inhibit the sympathetic, the predominant, which system do we have predominantly? The parasympathetic. When you inhibit the sympathetic, parasympathetic is going to be dominant. So you inhibit that, the parasympathetic will become dominant, which they have mentioned slightly here. The vagus nerve gets stimulated. Vagus nerve stimulation, which is parasympathetic nervous system, PANS. And that also leads to decrease in AV nodal conduction. And this, when you decrease SAV nodal conductions, you are controlling the ventricular rate of contraction. And this ventricular rate of contraction, it is used in AFib as well. Decreases the conduction AV SA node and depression of SA node. Decreases the ventricular contraction. That's how we use it in AFib. As it slows, again, let me mention here, as this will slows the ventricular rate by stimulation of parasympathetic PNS, parasympathetic nervous system, vagus nerve. Okay. And that is going to be all for the mechanism. Now let's talk about the adverse effects. Adverse effect of this digoxin is cholinergic effect. It's nausea, vomiting, diarrhea, high yield yellow vision, blurry yellow vision, van glow, arrhythmias and AV block. Arrhythmia and AV block. And what else? You will can lead to hyperkalemia. Why hyperkalemia? Because you are inhibiting this one. It's going to keep that that potassium outside, leading to hyperkalemia, right? Hyperkalemia, which indicates poor prognosis. Factors predisposing to toxicity are renal failure, because it decreases excretion of the drug. So the digoxin is excreted via kidney. So if there's a kidney failure, there's a decreased excretion. Hypokalemia. If you have an hypokalemia, which is the permissive for digoxin binding at potassium binding sites on the sodium potassium ATPase. Okay, drug that displaces the digoxin from tissue binding sites, that can also predispose them to toxicity and also decrease in clearance. For example, if you give with verapamil, amiodarone, and quinidine, it's going to decrease its clearance, again causing toxicity. Okay, so this is all. These are all the adverse effects of this, but on top of this, let's add some more adverse effects. In the heart, you will have any type of arrhythmia, which are going to be life-threatening. Arrhythmia, any type, but life-threatening arrhythmias. In the CNS, we talked about yellow color vision change, color vision alteration, weakness, fatigue, and confusion also there. Okay, And these adverse effects are most commonly coming when you have toxicity of this drug. And toxicity is either if you have one more thing on top of this, it's this drug, digoxin, it has a narrow therapeutic index, very high yield. It has a narrow TI, which is therapeutic index, making the toxicity relatively very common because it has a narrow therapeutic index. What is therapeutic index? Meaning if there's a concentration of drug, if you go above that concentration, if you don't maintain it within the concentration, if it goes above, it's going to cause toxicity, and it has a very narrow window of that therapeutic index. So there's a potential that it's going to go higher than that level if you're not monitoring well, and it can lead to toxicity. Okay, what else you might see here? If there is a toxicity, the antidote is high yield again. Antidote for this drug is you normalize, first of all, slowly normalize potassium. First, okay, before this, you stop the drug, okay? The first thing is to stop the drug. Stop drug. Second thing is you normalize potassium. Third thing is you give and third thing is actually this right here, which is high yield, is the anti-digoxin fab fragments. Anti-digoxin fab fragment. This is the antidote. And magnesium. What is magnesium going to do? Is a cofactor for, let me write, it's a cofactor for sodium potassium ATPase channel. So you give the magnesium as well. So for one more thing added to it, that digoxin binds, right? We said it inhibits that sodium potassium ATPase, right? So potassium and this digoxin, they are going to compete for the binding site. For the binding site, let's just change color. For the binding site of sodium potassium ATPase. So because sodium and potassium is binding, that is why you're going to normalize, and for the antidote, you're going to normalize potassium. You're going to give magnesium so that the cofactor for this channel to work, you're going to give potassium so that the channel starts working. That's one of the things, right? So one important thing is look at the toxicity. You will have toxicity when you have hypokalemia, because potassium is actively trying to bind to this channel. And digoxin is also trying actively to bind to this channel. They're competing with each other. But if you have low potassium, which is right here, you're going to have more and more digoxin binding to the channel, causing toxicity. Or if you give some diuretics that decrease the potassium level, that is still going to cause the toxicity. Renal failure, also important thing in renal failure. So in older patients, right here, let's talk about renal failure. Older patients, they have decrease in renal function because of age. As patient ages, the kidney function decreases. So for these old patients, you don't give the normal dosage of digoxin. You decrease the dosage of digoxin to not cause toxicity, because in old patient there is a decrease in renal function. So there's going to be decrease in renal clearance. So you prevent that by giving decreased dosage of digoxin in older age to prevent toxicity. Okay, this fab fragments for as an antidote, anti-digoxin fab fragments what's the mechanism of this thing? What it binds. Digoxin binds to these fab fragments more than the sodium potassium ATPase channel. So they bind to it, and instead of binding to sodium potassium ATPase. We talked about arrhythmia, as this is one of the things that is life-threatening. Life-threatening arrhythmia can happen with digoxin. So how do you treat that? You administer phenytoin. Okay, and if they go into heart block, you administer atropine. So AV block or heart block, atropine, arrhythmia, phenytoin. And that is going to be all for digoxin. So let's just quickly review the whole thing and move on. Digoxin inhibits sodium potassium ATPase at the same site as the potassium. It binds to the same site by binding to the potassium site on the pump. So potassium and digoxin bind. They compete for same site on this channel. When you inhibit this channel, you are indirectly inhibiting the sodium calcium exchanger. That's going to cause increase in calcium inside. That increased calcium causes binding of calcium to troponin C. That leads to contraction, which is your inotropy, increase in contractility, right? The same sodium potassium channel is also present in the neuronal tissues. That causes, when you inhibit the sodium potassium in the neurons, that's going to decrease sympathetic nervous system, and that is going to decrease SA and AV nodal conduction, and that is also going to stimulate the parasympathetic nervous system, and that will give you decrease in heart rate as well, and decrease in conduction at the AV node. So for clinical uses, used in heart failure, causes increase in contractility and AFib. Adverse effects: high yield or vision change or color vision change in the yellow color, and also arrhythmia, which is life-threatening. Treat with phenytoin, and AV block, treat by atropine. Can lead to hyperkalemia because potassium is outside. It causes hyperkalemia, which indicates poor prognosis. But the toxicity will happen if you have a renal failure, because this drug is renally cleared, and in all patients you decrease the dosage of a drug because, as you get older, the renal function decreases. So renal clearance of this drug will also decrease. So you decrease the dosage in all patient. So what is the predisposing factor to toxicity is renal failure. Hypokalemia, because potassium and digoxin bind to the same site on the sodium potassium ATPase channel. So if you have hypokalemia, more and more digoxin will bind to the channel and causing inhibition of that channel, causing toxicity. Okay, and or either the drugs that displace the digoxin from the tissue binding sites or decrease in clearance. What are the drugs that decrease clearance of digoxin? Those are verapamil, amiodarone, and quinidine. One more important point is going to be your diuretics, which decrease potassium. Diuretics with decreased potassium causing hypokalemia will also cause toxicity of digoxin. Antidote. For the antidote, you are going to give, first of all, stop the drug. Second thing, normalize potassium. Third thing, anti-digoxin fat fragments to which the digoxin binds and leaves the sodium potassium ATPase channel on side. Magnesium is a cofactor for the channel, so you're giving potassium, but you're also giving magnesium for the channel to properly start working. Okay, and one more last point: digoxin has a narrow DI, narrow therapeutic index, so be careful with the dosage. And that is all for digoxin.